So good afternoon everyone, and thank you chairperson as well as the organizers, and the disclaimer is that this is a sponsored session by Roche and a couple of slides have been provided by Roche. As the panelists and experts are settling down, I think since morning it will be a nice change. We have been discussing a lot about non-small cell lung cancer and developments are happening majorly in this field. But yes, there has been some development after the cystatin etoposide and illuminating which has happened over years. But now, yes, in last 4-5 years we had the Caspian as well as IM Power 133, and then now also this arena is expanding with lurbinectedin as well as other ADCs. And in this ESMO 2023, there were a lot of ADCs which have entered into small cell lung cancer, apart from immunotherapy. So let us start with the case. A 48-year-old young man, no comorbidities, but has a heavy smoker, presents to the ER with chest pain and breathlessness. As he lands up into the ER, he is referred to the cardiology team. They underwent angiography. The angiography was normal, and then a CT scan was done. And if you can see the CT scan, there is a mediastinal mass, mediastinal invasion, and involvement of major vessels. I will just show you the scan reports of the bed also. So there was an extensive mediastinal involvement, mediastinal lymphadenopathy, mediastinal invasion, large mass. Biopsy is suggestive of small cell lung cancer. MRI brain has been done. There is no metastasis. The patient has breathlessness as he had presented with the same thing, and is also in SPC syndrome. You can start with anyone. How would you like to manage this case? Kshitij, you're always on this side. You start.
Yeah, so patient is symptomatic for breathlessness, but as we know that it is a small cell cancer is very chemotherapy sensitive. I would like to start with a small dose of chemotherapy.
Start with chemotherapy. Anyone among the panel would like to refer to a radiation oncologist for SVC syndrome in this patient? No one. Okay, fine. So unanimous, we will start with chemotherapy. Okay, so we have all the options as you are aware. Patient is in ER for definitely has a compromised PS. What would you like to start with? We can take anyone. I mean, Vaibhav.
Choice of regimen, sir. Yeah.
So a compromised PS, young patient, SVC syndrome, is in ER and in cardiac ICU, angiography normal. This is usually, I will say not usual, but yes, you do face this situation quite often. So would you like to start? These are all the options which are available to you.
Yeah, obviously, sir, with the new data coming in, I think carboplatin etoposide plus tecentriq followed by maintenance tecentriq or even the Caspian data. That should be right.
So you would like to start with all three together, or you would like to start with a single agent, or how would you like to start with this?
Sir, actually, the problem over here which I could figure out was the SPCO. Apart from that, there was not a big deal. So here what we do is we take care of three things. One is the tumor-necrosis syndrome, just to look at the baseline LDH and then treat it if some prophylaxis is needed to give it. Also, the practical thing is what we were taught in Tata Hospital was that to start the first cycle from the lower extremity in such cases, because when you give
that is all okay. You have taken the care of hydration, you have not overhydrated, you have given nebulization, you have given steroids, patient is stuck on a low volume and mid-bile towards the dehydrated side. You will give all three together in the first setting, you will start with a single agent or
all three.
So last month only we had similar patient, exactly similar, very poor PS. We started with a single agent carboplatin. And in spite of single agent carboplatin, patient landed up with DLS and hypoglycemia, admitted in the hospital, and we recovered that. And the second cycle, carbo-eto is completed now. So it's initially it's a little bit tough, so we sometimes start with a single agent.
Yes, so definitely, I mean, when we are looking at these drugs and when we add IO in a small cell lung cancer, the IO has been added in a small cell lung cancer not to increase the response rate. Like in adenocarcinoma, you do see when you add pembro to chemo that there will be 10 to 15-20% response rate. The whole idea to add here IO was to reduce the chances of failure. It was not that we were not getting good responses with the platinum or etoposide. We are already getting 85-90% response rates. And especially when you load the patient with all the three drugs as Kshitij said, you may land up into trouble. Especially when you are giving immunotherapies, you are always worried about the immune-related adverse event with the chances of lung toxicity. And it's very difficult to differentiate at that time what is happening. Anyone would like to make a comment? Dr. Ganapathi or Dr. Akhil, any other comment apart from what has been discussed for this patient, particularly restricting your comments to this patient?
Only one thing is which might be needed is if the patient is a frank SPCO, it is patient is requiring high flow oxygen. At that juncture, that interventional radiology opinion might be taken if we require immediate, for example, if we want to get an stenting done. But most of the time, it is settled in our practice. Small cell responds very well and fast. It is an extraordinary patient where the patient is already desaturating, not maintaining. Then we might consider, but it is already, we have missed the boat if the patient is already in that situation.
Okay. So the point well taken. Akhil wants to make a point that you have to rule out thrombosis. Basically, what he wants to say, and I also do that. If the patient is having a good of creatinine, I always do a CT angiography in these patients, not for pulmonary, but to rule out SCC thrombosis because the Doppler will miss. And yes, in 5 or 10% of the patients, or in an odd case, you will get a thrombosis. And in that, it's better to start anticoagulants, and that point has to be kept in mind of SCC syndrome versus SCC thrombosis when you deal with these patients. So I think Akhil, you can take, how do you decide between Caspian versus iron power 133 and then Anup, and so any preference, any point, because you have both the trials, you have both the results available. So how do you choose between these two trials?
Yeah. So
or it is a Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday is wrong. Sunday you give carboplatin, patient is sick. Give only carboplatin when they land up in emergency, or cisplatin weekly.
Basically, two trials are very comparable.
And this patient is not having any brain metastasis.
So basically, the two trials are very comparable, very similar designs. So there are some small differences. For example, in iron power we can see carbo only, while in Caspian it was cis and carbo both. But most of the time in our real practice we utilize carbo only. So that doesn't make too much of difference in the routine practice. Another point which is important is regarding the eligibility for the PCI. PCI was.
We'll come to that. PCI will come to you. Apart from the brain, you discuss. Please give comments apart from the brain part. We'll come separately to the brain data.
So these two both are.
So does the other panel also agree? Actually, in my practice also I have shifted to carboplatin, or does it make a difference whether you are using immuno or not, that you will decide cis versus carbo and eto? Anyone, Anu? Any choice that if you are not using immuno versus immuno, or everyone goes on a carbo? As Akhil said that most of the time we are using carbo only, and that was what was there in iron power 133.
Yes, sir.
Whereas you had an option of using cisplatin and carboplatin in Caspian.
Practically every patient of mine generally goes on carbo, less phototoxicity, nephrotoxicity, better way of giving. Generally, this patient a smoker, elderly, comorbidity, giving cisplatin with hydration is a bit challenging.
So anyone who is preferring a cisplatin, or everyone is by default the option is carboplatin.
Usually it is carbo only, but only one situation when the patient has small burden of the disease and the patient can go undergo significant hydration without any contraindication, then only we consider. But most of the time we get SPCO, early SPCO at least there, patients with widespread disease, liver mets are already there, then we actually prefer carboplatin. In actual setting, if you ask, 95% patients will receive carboplatin, maybe 4 to 5 only.
I think out of the institute and practice also both ways carboplatin is fine. Yes, sir. Sir has a comment.
One comment. Cisplatin will be less myelosuppressive. So myelosuppression when you are thinking of, I think cisplatin. Otherwise, better is shown response point, everything like it's nearly the same.
And I think point very well taken by sir that yes, these patients do land up with marrow metastasis. I had 2 in last 6 months, and there you definitely can start off weekly cisplatin if your marrow metastasis is extensive, because weekly cisplatin will be very easily tolerated. 4 versus 6 cycles, Kshitij. Dr. Ganapathi after Kshitij.
4 cycles.
I want your comment that whether you are using IO or not. Does that matter? If you are using with IO, you will use 4. Without IO, 6.
My initial plan will be 4,
Yes.
and re-evaluation after the 4 cycles.
Sorry, can you come again?
My initial plan will be 4 cycles. Then re-evaluation of the disease status after the 4.
Okay. Kshitij, I will come to you. So you use 4, PET scan shows a very good response.
Yeah.
You put them on maintenance IO.
Yeah, maintenance.
And if the patient is not available for IO, then what will you do? 4 cycles that do a PET scan, very good response. Then
the maintenance.
What maintenance? Patient is not affording for IO. Patient is not affording for IO. You have not started them on chemo IO, only chemo. Sorry?
Chemo extend to 6.
So that is what I was asking, that if you are using IO versus not IO, somewhere is there in the mind that maintenance will take care and you can omit 2 cycles. But we have data where IO was not used, and this is what was there in the meta-analysis, that without IO also the OS will not make a difference. So if the patient is not affording IO, and Kshitij, you can comment on that, are you comfortable with 4 and stop? And then re-challenge when he progresses or as per the progression, or no?
So usually in current practice I will try to complete 6.
You will try to complete 6, even with IO?
With IO we have a data to stop after 4.
With IO you have a data to stop, but without IO also this is not, I mean that was the rationale of using 4 cycles in IM power 133 was based on the meta-analysis that if you use 4 versus 6, the OS differences are hardly a month and that was not statistically significant. So even before IM power 1, why IM power 133 used 4 was this slide. So that is why I am asking you, why do we give 6 when we are we are used to giving 6, but 4 is also okay even if you are not using IO as a maintenance. That was the point. Anyone would like to have a contradict to this, or they are okay? Okay. Sir, your take? You are okay 4 without any IO maintenance? Without any immunotherapy maintenance, 4 cycles finished, stop. Very good response. Patient has almost a near CR.
If we are not using an IO,
no IO, sir.
Then if the patient is tolerating well, I may go to 6.
Okay. So the consensus is to continue 6. I think there was, we have discussed carbo cisplatin and dose reduction. I think we will all do it in elderly.
Actually, there is a recent data I think you wanted to illuminate 4 versus 6 cycles.
But I think we are not, all of us, I mean it is, that
if the patient is tolerating, why not to complete 6
why not to complete?
At the back of mind.
And the point is that what sir also said is very right, that if the patient is not tolerating and you have done 4 and he has some toxicities of grade 3 or more, then but you can actually stop at 4 without losing anything and then re-challenge as per the progression and the platinum-free interval. So this patient was started on atezolizumab, since it is a sponsored session by Roche, they had to go on atezolizumab with carboplatin doublet, completed 4 cycles, no adverse events. There was a good response, near complete CR. And patient is now PS0, he is young, he has gone on an atezolizumab maintenance. I think the PFS data we have. So before we go to the long-term OS data, this was what we were having, the 2-year OS data of 16 versus 22%. And similar data is also there for Caspian study of 5.8 versus 17.6%, but all 13 versus 22% at 2 years. And as Akhil also said, anyone would like to make a comment with respect to the OS data? I mean, there is no difference between the 2 trials to my mind. You can use any of them depending upon your comfort and experience with the molecules. So we come to PCI. I will take Akhil's comment since he was making a comment at that point. So I will ask Akhil and then Anup. Yes, Akhil, PCI you will offer or not? Let's stick to this patient only. Has a very good response.
Patients having good response, but if patient is the way of the various trials, Japanese trial we are all discussing at multiple time points. If the Japanese study, if we are able to do surveillance at 3 monthly interval, then it is fine to avoid PCI. In routine practice, we utilize PCI in a large number of patients. Why? Because the patients these patients might not come back to us at the correct time. The compliance in our country is an issue. If patient has got very good response, there is no large disease, extrathoracic disease is remaining. These patients are actually can be given PCI. So we consider it.
When we talk about omitting PCI, you will agree you will do it only in the patients who are on IO maintenance. You will not do it outside IO maintenance. So they will be in touch with you and they will be in follow-up for, at least they will be coming for IO. So follow-up will not be an issue of India.
Yeah. So when the patient is IO maintenance and has agreed to do MRI, I don't do
and once they are on IO maintenance, you will do an MRI surveillance and then pick up early.
Yes.
Anyone else? Anup, Rushabh, what is your practice? Yes, sir.
Anup
and Rushabh and then sir. Yes, sir.
I concur with Akhil. Now 5-year data coming for survival, we need to look also at the long-term side effects of PCI. So if patient is agreed to be on surveillance and sticking IO, better to do it.
And are your radiation oncologists comfortable with this concept? Because if you send them, they do offer that. And then it becomes very difficult because on surveillance, if a patient has a med, at that point saying that the radiation people was wrong, right or wrong becomes difficult from the patient perspective. It is not our perspective. We know that OS is not changing. And I have sent 10 patients in last 1 year of small cell, and all of them have been prescribed PCI. Though in couple of them they did agree that yes, you can avoid that. So are you facing any challenges from your radiation oncology colleagues to avoid PCI?
Yeah, definitely, sir. They will be hell-bent on giving PCI.
Rushabh?
So it is safe, sir. So when
are you comfortable in omitting?
So
yes,
if
yes or no?
Yes.
And are your radiation oncologists comfortable in omitting?
So we need to talk to them. They generally would prescribe if you have not talked to them.
Yes, I have also realized if you tell them that they are on IO and the data and they go and look back and then they come tomorrow or the next morning, they do say that yes, you can give an option of avoiding. Yes, sir.
Just a counter question. If your patient had asymptomatic brain mets at presentation, what will you have done?
What will be the IO when you have a brain mets? Okay. Anyone?
Asymptomatic brain met.
Asymptomatic brain mets present before, but when we are doing response assessments, such patients will also undergo MRI.
No, there are two questions there. So, sir wants to. One is this, which I have put it, that someone has a brain metastasis at diagnosis. And what will be the treatment? Whether you will do. It's a asymptomatic brain mets. So, Akhil, we divided into asymptomatic, symptomatic brain mets. So, de novo brain metastasis, asymptomatic. So, let's take a comment from the panelists. What will you do and what will be the IO drug of choice in that case? Asymptomatic brain mets, would you subject them to radiotherapy and then go to chemo IO or directly to chemo IO?
Asymptomatic patients we usually do not give radiation because carboplatin itself has good penetration in the brain and will take care of the brain mets as well in most of the patients.
Any experience? I had done it in one patient and luckily the patient has been well. Your experience? I mean, I have done it in one patient. He had brain mets. He was not agreeing. The radiation oncologist was comfortable. Only 2 brain metastases were there small. He did not give radiation, and the patient had done well. But the reason of not giving brain metastasis in my patient was that they had extensive liver metastasis, and so the radiation and the whole team was understanding. But there was a good tolerability to chemo in that patient. Brain metastasis was controlled.
These patients, I think so. After evaluation, you may consider radiation. After 4 cycles.
So yes, that will be, of course that will not be a PCI, but yes, you can actually give, that yes, if you are not giving at diagnosis, then once you have given a chemo or even chemo IO or chemo, after 4 cycles when they go on maintenance, at that time we should not be too heroic to omit radiotherapy in these symptomatic, asymptomatic brain mets. Yes, sir.
So, what we are looking here, why we want to avoid radiation to brain, we want to understand this here. If the patient is able to survive beyond 2 years, there are chances of radiation-induced dementia and other changes in the brain.
And patients are surviving. I mean, we have around 25% of the patients who will survive till 2 years or 20%.
That data becomes very important for us when we are discussing the case with our radiation oncologist. If the patient is completely asymptomatic, patient is able to afford immunotherapy and able to continue immunotherapy maintenance, then this data helps us discuss with our radiation oncologist that yes, we can avoid radiation for now. Even the PCI can be avoided based on this data that all patients will not require radiation for a long time. And PCI might lead to deterioration in the quality of life later if the patient is surviving for more than 2 years.
Anyone?
Just a question, I'm not answering this thing because many things that CNS metastasis are. So my question is regarding immunotherapy penetrance into brain.
See, I think it is not about immunotherapy penetrance, it is about the data that we don't have any, we have the data in our hand, and I will just come to that, is that if you are using IOs and they have omitted, so what has happened is not that IO has done something wondrous, that the trial has been designed luckily in that way that there was an option of omitting PCI, and even after omitting PCI you have an OS advantage of 2.5 months, which is clinically, it is clinically and statistically significant. And more important is that the patients are, double the patients are living, and we all know that when these small cell patients die, they have their brain metastasis inside them, and as we say about many prostates will die, elderly will die, it's about small cell also. If you do an autopsy and you know there will be 50% who will have some brain metastasis or histopathology. So it is that the evidence is not there of, we have now evidence available, and luckily both the trials had an option of not giving PCI. And the second question always comes is about thoracic RT. These patients do respond well, and there is the CREST trial, and again the evidence is weak. It is almost equivalently weak. Similarly, like for brain RT, always the discussion is that thoracic RT, will you do it or not? Of course, the caveat is that there will be a very good response everywhere, and then there is the lung mass left. Vaibhav, what will you do? You will offer a thoracic RT, and will there be any situation where you offer only thoracic RT and not PCI?
Now,
and then how will you convince your radiation oncologist that radiation lung ko to de do aur brain ko chhod do?
So now actually this has to be individualized because since patient is on immunotherapy, then it's not a must to give RT. But if patient is not on immunotherapy, just I am doing 6 cycles of etoposide, then yes, if there is only intrathoracic disease, it is worth. It will prolong the PFS or whatever worth it is. With immunotherapy, because there is a risk of cumulative toxicity, both radiotoxicity to the lungs as well as the pneumonitis. So it might actually lead to some complications.
Dr. Ganapathi, point very well taken.
So, in elderly patients and those who have immediate mass predominant and hence symptomatic of severe cough on presentation and patient not opting for immunotherapy. These are 3 indications where you have to the first.
So I think point very well. Both the experts have put it very well that once you are, especially in these scenarios when the patients are on, not on IO, the thoracic RT becomes more important as a consolidation, especially with a very good response everywhere. And with IO, there are more so reasons to avoid, and of course elderly and anyone who is not having a response, we will definitely not subject them to thoracic RT. Any preference, Atezo versus Durva in brain mets? We have data both ways. These are actually the snapshots from one is of Roche and down is from the AstraZeneca slide. I am actually confused and I still feel both the drugs work equally there. We can't compare it, but one is IM power 133. It is 16 versus 9 months for the intracranial progression. And we all know that PCI was optional and the AstraZeneca trial is also for the patients who have no brain progression and they don't go on brain RT. There also, if you see, there is a 19 versus 10 months difference. So both the drugs are doing some activity in the brain as compared to chemo, and this was also one of the questions raised by the expert that yes, we have data, and this is the slide which also suggests that yes, something they are doing extra in controlling brain metastasis. Any preference of one over the other, or to your mind after seeing this slide, or with your experience, you feel both the drugs are equal and you will not give preference of one over the other in patient who is having a symptomatic brain metastasis at diagnosis?
During the inclusion criteria, I think there was a inclusion criteria for durvalumab of taking 3 to 4 weeks of steroid and controlled brain mets.
It was in Caspian. Yes, Caspian had that, yes. Controlled brain mets.
It is what I think.
That is the one positive point in favor of Caspian, yes. But in your practice, will you give Durva only to all 100 patients or all 10 patients who present in next 2-3 years? All of them with brain mets will go on Durva plus O, or no? Not like that.
Now PAP is different, so practically it is
PAP is different. So we will come to PAP also. PAP will make a difference. Okay. Good. And that
practically we don't prefer the basis of brain mets.
Kshitij? Yes, please, Anup.
So I agree with this because we have a good experience of Atezo.
Okay, so it is your experience that. Yes.
Except for the thoracic RT, practically what happens is this 90 to 95% of patients are elderly, smokers, they have underlying COPD, sometimes ischemic heart disease. So it is better to avoid thoracic RT for consultation.
Okay, fine. So that point we have already covered. Now there is an OS data. I will just go through that data in a while, just in 1 minute. So 5-year survival data, the trial is called Umbrella A. It is an extension study, and how it is an extension study are that those patients who were having a disease control and were put on atezolizumab maintenance. So there is a positive selection criteria here that patients who were on IM power 133, they are having their disease control and then they go on atezolizumab maintenance. They have been followed in this trial till 5 years, and that is how the 5-year survival data has come. And then this was exactly that Atezo patients till the deadline of 2020 as per the trial, they have gone and they were eligible for this follow-up study. And this is the results. That is the first data set we have. 3 years 16%. And if you see, I was really thrilled to see that from 3 years to 5 years they have only lost 4% of the patients. So again, what Dr. Ashish was also showing that even in non-small cell, the patients were completing 2 years. I think there were around 72% of the patients who were doing well. So here also, if you see, if they're completing 3 years, and we all know that 3 years is actually a very, very major landmark to achieve in an extensive stage SCLC. And after that, they have just lost 4% of the patients. Now, and this is what the Caspian has a 3-year data set. Now, with this data set, I think there was a comment from one of the experts that we have a long-term data. Does this takes your prescription towards atizo or not? I think the normal people who are sitting, they will be interested to know that once they have produced this data of 5-year of 12%, is that making you think that yes, atizo is a better drug, or it is just the lack of data of Caspian and it does not push your practice towards atizolizumab? Anyone can make a comment, anyone. Or it is just that they have the data and it will not make a difference. Yes, sir.
And just make a statement what up to date has given.
Sorry, sir?
What up to date has given a statement.
Yes, sir, please.
That how to choose. Availability, that's the thing. And your preference and what you have experienced. That is what up to date has given when you have to choose between it.
And that is what is, as per the experience also, it's about your availability. And so if I take a unanimous no that this 5-year data of 12% does not tilt the prescriptions towards atizolizumab. No?
Sir,
you can say no or yes, and we did not justify it with our statistical jargon. It is just no or yes. Sometimes we can be very simple, no or yes. Yes, no or yes.
Sir, it is lack of data of Caspian.
So no or yes?
Not because of this, it is
no. Okay. Anyone? Yes?
Yes, sir. Because
yes.
data is
Kshitij, no or yes? Yes or no? No explanation. Yes or no? Yes. Okay. So two are yes. One is no. We have more also. Yes. Yes or no? Yes. Third yes. Okay. Akhil, you are left. Yes or no? Yes. Okay. So we have 4 yes. I mean, it's a biased. Maybe it's a Roche sponsored symposium. This question would have been more apt to be asked in an AZ sponsored symposium that does this tilt your prescription towards atizo versus durva or not. And I think one is what is more pertinent to our subset is, I think we have discussed this. We all know this, and the last interesting question is yes. And this is more of a financial and a financial economic. We can have comments from Kshitij to everyone. We have a new PAP. We are all aware that this PAP makes us, the drug cost around for 1 year is I think around 4 into some 9 lakhs something. 10 lakhs, no, sir? 10 lakhs per year. 12 lakhs. 4 doses are 12 lakhs. So 12 lakhs per year, and this is more now a pharmacoeconomic question, and it is now, does this improve your patient going on atizo versus durva? And this is purely a non-scientific question, and sorry to put you on this spot. Yes, please.
Yeah, definitely, because as we are practicing with the patient, real life patient, the finances is.
So Monday morning, everyone goes on atizo with this plan. Yes, the patient is paying from the pocket, why not? After all, you will expect them to go for 8-9 months, then also it is helpful in small cell, even not for years. Yes?
Yes.
Yes, okay.
Yes.
Yeah, actually it's very good, and also the PAP process is also very smooth with Roche actually. That I will need to compliment.
A decent one. I will not label the indecent proposals which have been there from the pharma here, but yes, a decent proposal, yes. Process is decent.
One comment, just to appreciate them, they have a PAP program which is irrespective of even the diagnosis also. So, where the rare diagnoses are there, still PAP is applicable, which is not with other immunotherapies.
Okay, I was not aware that they are covering, anywhere they are using it. Okay.
Sir, just wanted to ask a question. Whether we will continue IO on progression? Because we are challenging after 6 months and within 6 months.
So if someone would have been on atizo maintenance and has progressed, they will not go on a re-challenge IO. Even we are fighting with the re-challenge IO in non-small cell. In small cell, I would never re-challenge.
I would suppose IOT plus IO for second.
I would not do that. We don't have the data. We have data for third line IO if you have not used IO in first line. So if you have used someone on cis keto and then they progress, then you can use, there is data for both Pembro as well as atizo in the third.
No, sir, it's not re-challenge. It's like continuation beyond progression. So suppose after 6 months relapses, you want to re-challenge with card.
And they were on a IO maintenance.
They are already
no. Just put them
continue IO, stop IO, and then re-challenge with keto.
So I have faced this situation twice. I have stopped the IO maintenance and I have put them on irinotecan cisplatin. What I don't know here is that I am increasing the platinum-free interval by giving IO, but anyhow I am increasing it, like in ovary we increase it by giving PEP. I have put them on platinum and irinotecan, both of them. I think we have come to the end. 20 seconds left. Any comments from the panelists and any question from the floor before we wind up? Or before we hand it over to the...
Just one very relevant comment, sir.
Yes,
in those long-term responders, 5 years, we see 12%. So, is there a case of stopping at least after 2 years or 3 years, though there was a flattening there?
In small cell, there are events happening after 2 years. You can see 22, 16, 13, 12. I think here I would not like to stop. It's a different disease, it's a different biology. And till we have that data of stopping, maybe after 2 years or maybe after 3 years, yes, but there are events happening still.
Just a last question.
I think the time is up. Sorry, Kshitij, I will have to stop. Any question from the floor? And we will have to give time for the sir's comment because that is why Kshitij, I had to stop you. Please apology. Sir, your last winding comments.
No, it was a very nice discussion and it was very insightful discussion and we really all enjoyed it. But we all are talking about these two. But there are two more Chinese immunotherapeutic agents which have been approved in China, and they have shown similar PFS. The names are very tongue twisting, but there are two, and they are all published phase 3 data. So we forget about those two immunotherapeutic agents also. One is I'll have to open up and see saprolumab and one is adimabaprilumab. So these are also there just as a part of information. Thank you very much.
Okay. Thank you. Over to the organizer.